hepatitis. Mhm. Hello. Yes, a little delay. So today we have a lecture on viral hepatitis. It's big and interesting topic. So to begin, what is viral hepatitis at all? Yes, viral hepatitis is a large group of infectious disease with a primary lesion of the liver, which have similar clinic but differ in etiology, pathogenesis, severity, and consequences. In the 5th century BC, Hippocrates described the relationship of jaundice and ascites with liver disease. It's just a bit of history, yes? In 1938, the beginning of the study of viral hepatitis, when the British virologist Findlay and McCallum described the outbreak of hepatitis following yellow fever vaccination. Currently known 8 agents of viral hepatitis. Viral hepatitis A, viral hepatitis E, viral hepatitis B, viral hepatitis C, viral hepatitis D, and viral hepatitis G, TTV, and others. The most dangerous, and we will talk on this course of 5, A, B, C, D, and E. The most dangerous for the population are viral hepatitis with blood contact and vertical transmission, B, C, and D, because of the high probability of development of chronic forms in viral hepatitis C, and liver cirrhosis and hepatocellular carcinoma. These effects lead to reduced life quality and significant economic loss. Pathomorphological changes of viral hepatitis. Mechanism of them is different. In viral hepatitis A, C, and B, they have direct cytolytic effect. And in hepatitis B virus, it is indirect via the immune system. Other symptoms, so cytolytic effect plus intoxication. Well, again, intoxication, syndrome of cytolysis of hepatocyte, cholestasis syndrome, hepatocellular insufficiency, mesenchymal inflammatory syndrome. Characteristic of pathogenetic syndromes of viral hepatitis. Intoxication syndrome, pathogenesis, accumulation of toxic metabolites due to damage of hepatocytes and violation of their function. Clinical characteristic, hypertonia, febrile or subfebrile, headache, dizziness, weakness, loss of appetite, nausea, vomiting, body aches, myalgia, arthralgia. Yes, well, all symptoms of general intoxication. And laboratory, you can find it where increased level of blood urea, creatinine, yes, intoxication. Then syndrome of cytolysis and of hepatocytes, pathogenesis. Local membrane damage of hepatocytes and infiltration into the bloodstream of the active intracellular proteolytic. Clinically, it shows as hepatomegaly, weakness, hypertonia, and it causes increased level of ALT, AST, and LDG. Cholestasis syndrome. Dysfunction of aspiration of bilirubin connecting with glucuronic acid, direct fraction from hepatocytes to bile ducts. Clinically, jaundice, itchy skin, darkening of urine, discoloration of feces. Laboratory, increased total bilirubin and violation of the ratio of direct and indirect fraction in the upward direct. But again, it's not only about jaundice. Jaundice and bilirubin, it's just about jaundice. And cholestasis, it's similar, but in express cholestasis, each skin is added because each skin may be present. Like when you talk about jaundice, it's darkening of the urine, discoloration of feces, jaundice of sclera, of skin, but itching may be present and may be absent. And if it's about cholestasis, itching, so it goes along with jaundice syndrome. But if it's with cholestasis, itchy skin dam added as clinics, and laboratory alkaline phosphatase rises. And in treatment, yes, why we should think about this. So we may prescribe any hepatoprotector if we talk about hepatitis at all. But if we talk about cholestasis and patient complaints on itchy skin and you see increased alkaline phosphatase in biochemical test, you should use or add ursodeoxycholic acid, but specifically for cholestasis. Then, mesenchymal inflammatory syndrome, proliferative infiltrative changes in the stroma of the liver, hepatomegaly, discomfort in the right hypochondrium as a clinics, and changes of protein sedimentation sample in thymol test. Thymol test especially typical for hepatitis A. Hepatocellular insufficiency, destruction of hepatocytes, violation of their function, clinically hemorrhagic syndrome, bleeding gums at the site of injection, severe form, nasal, uterine, intestinal bleeding, prolonged menstrual period, peripheral edema, ascites, anasarca, and severe failure. Laboratory characteristic, altered coagulation, decreased level of prothrombin, fibrinogen A, and appearance of fibrinogen B, decreased total protein. Again, but hepatocellular insufficiency is severe course or complicated. Normally, it should be absent in moderate to mild course. Clinical classification. It's acute hepatitis A with or without hepatic coma, acute hepatitis B in co-infection with D with or without hepatic coma, without co-infection with D hepatitis with or without hepatic coma, other acute viral hepatitis, D as superinfection in carrier of HBV, acute hepatitis C, acute hepatitis E, other verified acute viral hepatitis, acute unverified viral hepatitis, chronic hepatitis B plus D, chronic B without D, chronic hepatitis C, other chronic viral hepatitis, chronic hepatitis unverified viral hepatitis, yes, unverified viral hepatitis with hepatic coma and without hepatic coma. Acute hepatitis is up to 6 months after infection. If after 6 months after infection symptoms still stays and a virus still detected in the blood, then we talk about chronic hepatitis. It leads to cirrhosis, but usually it takes time. It's not like you have the hepatitis, the next day you have cirrhosis, yes? Acute liver failure, maybe. But cirrhosis is a replacement of active tissue with connective tissue, so usually it takes years, maybe about something like 20 years. And also it may lead to oncology, yes, liver cancer, hepatocellular carcinoma, but again, it's usually not that happens in a day. It takes 20, 30 years to cause cancer. Clinical classification. On the duration and cyclicity of course, acute, up to 3 months, subacute or lingering, 3 months and more, recurrent, fulminant. Fulminant is super fast. By severity, according to hyperbilirubinemia, mild form, up to 100 millimole per liter, moderate form, up to 160, and severe form more than 160. It's one of the classification. Actually, I saw several sources, and in different sources, numbers be different. So there may be, I saw like 120 mild to moderate and more than 20 severe. But again, at least for you to at least approximately know, yes? Up to 100 mild, 100 to 150, or I would even say to 200 moderate, and severe more than 200 or and so on. According to expression of clinic, icteritic form, again, so it may be icteritic, but it may be anecteritic. In icteritic form, it may be typical cytolytic or cholestatic. Yes, which itching skin, which alkaline phosphatase, or just cytolytic but still icterytic, yes? Anicterytic form also may be. It's usually mild forms and often goes to chronic form, but again, anicterytic form may also be present. Then subclinical forms, obliterated forms. And main with jaundice. We may not say what causes jaundice, maybe mechanical jaundice, maybe even malaria, yes, severe forms, or any other damage of the liver, but here we see jaundice. Yes, and it's not only about skin, but about sclera, jaundice of the sclera is seen. Next. Viral hepatitis A, start with it. Intestinal enteropanotic viral infection with fecal-oral mechanism of transmission, characterized by hepatonecrosis, clinically by intoxication, hepatomegaly, sometimes jaundice. Again, sometimes jaundice. For kids, most cases happen without jaundice. An outbreak in some kindergarten, uh, only a small amount of children, maybe 10 or 20%, will have jaundice form. Most will have non-jaundice form, if we talk about hepatitis A. In adults, jaundice form more often, more spread than among children. But usually it's considered to be kids' disease because of the lower hygiene level. Etiology: hepatovirus, picornaviridae, has a rounded shape, a single chain of RNA, stable in the environment, for eaten stored for about 1 month, non-activated by stomach acid, sensitive for ribavirin, amantadine, but still we don't use usually antiviral drugs. Epidemiology: fecal oral mechanism of transmission, mostly water route, maybe alimentary route, contact waste through dirty hands, towels, linen, and dishes. Source: patient in incubation, prodromal period, and climax of the disease. With the nephrin on obliterated and anicteric, more dangerous form. I mean, more dangerous epidemiologically, because you don't know that he have hepatitis. After the appearance of jaundice, the risk of infection is reduced because excretion of the virus reduces too. Susceptibility general. Children after the first year of life is more susceptible again due to hygiene level. Teenagers, young people 35 years. But really, I had a patient 50 years old with hepatitis A, which is really rare, but it happens still. Patient with immunosuppression. Again, it's more typical for young people. Seasonality, summer, autumn. Factors: contaminated water, infected food products, household item. Epidemics occurs every 4-7 years. Repeated infection is not seen. Usually person have it only once in a lifetime. Pathogenesis. Damage of hepatocytes due to cell cytotoxic immune reactions and direct sympathetic effects of the virus. Main link of pathogenesis is biochemical reaction, peroxidate oxygenation of lipids, leading to destruction of hepatocytes, phospholipids, and increased membrane permeability. Phases: penetration of the virus into hepatocytes, reproduction leads to cytosis and degeneration of cells, excretion. Virus enters from affected cells via bile in the intestine and excretes with feces. Clinical characteristic: cyclic disease. We have an incubation, initial period, climax, and reconvalescence. So incubation, asymptomatical, duration 10 to 15 days, incubation period, average about 28 days. At voluntary and elementary ways is shorter, in contact longer. Initial period, duration 5 to 7 days, and it have initial period may occur in several clinic variants. Flu-like variant, hyperemia, nasal congestion, discomfort in the oropharynx, coughing, dyspeptic, anorexia, nausea, vomiting, stomach pain, diarrhea, asthenia vegetative, general weakness, irritability, indifference, insomnia, drowsiness, and mixed form. Also, in this period, intoxication takes place, hyperthermia up to 38, 39, headache, weakness, dyspepsia maybe, again, intoxication, loss of appetite, nausea, vomiting, feeling of heaviness in the epigastrium and right hypochondrium, and start off darkening the color of urine. Again, maybe in unjaundiced form, changes of the color urine will be absent, of course. Climb, icterial period. We talk about jaundice form, so jaundice appear. With this appearance, patient stage is improved and its additional diagnostic criteria. First painted the mucosa of the arepharynx and the sclera, later the skin of the trunk and then extremities. The course is usually 2-3 weeks and has for 3 phases: progression for 3-4 days, peak 1-2 weeks, and attenuation 2 weeks. Discolored stool, dark urine, dark brown like root beer or black tea, foamy, enlarged liver and spleen, palpation is painful, dense liver tissue, cardiovascular syndrome may be sensitive to hypertension, bradycardia. Reconvalescence, continuous 3-6 months, jaundice disappeared gradually, and steno-vegetative syndrome left over after the disease. Laboratory characteristic. Specific method. Method of isolation of virus, virological detection of the virus in the feces during initial period, or it also may be with rapid test we may find virus in the feces, especially during initial period. PCR, from the first week of the disease, we can use PCR to detect virus in the blood. Serological confirmation. ELISA, relieving of hepatitis A virus immunoglobulin M, determined in the acute period of the disease, maximum titer in 2-3 months and persists for 2-6 months. R and anti-hepatitis A virus immunoglobulin G, identified through all the lifetime after the disease. Usually it's appeared on the 2nd, 3rd week. Detection of anti-HAV immunoglobulin M indicates the presence of current acute infection, or maybe just again, maybe it in recovery stage, but still it like maybe only 2 months have been passed through it, yes, because it stays up to 6 months. But high titers of anti-HA hepatitis A immunoglobulin G confer immunity from infection or vaccination, because for hepatitis A, vaccination is possible. Really, really rare, it may be carriage of hepatitis A, but it's so rare, I don't even know why didn't I remove it from the lecture. Okay, whatever. So usually immunoglobulin G is for past infection or vaccination. Non-specific method. In CBC, you will find leukopenia, neutropenia, relative lymphocytosis, normal ESR. Biochemical tests of the blood, increased transaminases, especially in initial period climates, especially ALT as a marker of cytolysis above normal in 10 times at least 10 times. It may be 10 to 100 times. Reduced in reconvalescence. Hyperbilirubinemia due to direct fraction in icteric period, indicator of the severity of the disease. Increased alkaline phosphatase in cholestasis, if it will be cholestatic form, LDG. Increased blood urea in severe forms. Coagulogram, usually no change. Urobilin again in urine. Complex of clinical anamnestic data of viral hepatitis A. Cyclical development, presence of prodromal initial period, sequences of development of intoxication, jaundice, and hepatosplenomegaly, epidemiologic anamnesis, contact with patient with hepatitis A, using of unboiling water, and hygienic behavior. Laboratory data, hyperbilirubinemia, direct fraction, increased transaminase, urobilin in urine, markers, anti-hepatitis A, immunoglobulin M. Viral hepatitis B. Mixed viral and tropanotic infection from the group of transfusion hepatitis characterized by lesions of hepatitis and occurring in different clinical forms. Hepatitis B occurs in chronic, lingering, and acute form. In 1963, Bloomberg isolated from the blood of Australian Aborigines special Australian antigen, which is considered a marker of serum hepatitis. And now it's one of the name of HBS antigen, Australian antigen. Maybe you heard of it. Dane in 1970 identified a new virus of hepatitis, justifying the existence of a new nosological form, viral hepatitis B. Acute viral hepatitis, spherical form, is of hepatadenovirus and orthohepatadenovirus. Species spherical form, lipoprotein envelope, which is HBS antigen, nucleic capsid, DNA, genome contains S, T, X, P genes. Main viral protein are encoded by genes S. Well, actually, it's not that important, really. You can read it yourself. Anyway, But next, all these proteins can be found in plasma during replication of the virus. The GNC encodes protein of nucleic capsid HB core antigen. It is only inside hepatocyte, but his soluble antigenic variety HBE circulates in a blood and has three reservoirs. GenX activator of all genes HBV probably in this induces appearance of a hepatous cell carcinoma. Patient have the high level of anti-HBX. The GNP occupies 80% of chain DNA, encodes DNA polymerase, concentrate ribonucleases. The surface antigen HBS has four main subtypes. There are three virus-specific antigens. That's now it's more important. Antigen of replication, HBE, HBA antigen is antigen of replication. Core antigen, HB core antigen, and surface antigen, HBS antigen, or Australian, it's surface. Detection of circulating immune complexes in 3-4 months after the onset of the disease means presence the risk of chronization of the process. Favorable signs of prognosis of the disease is disappearance of the surface antigen and formation of antibodies to HBS antigen, indicating a stop of the viral replication. Properties. Stable in the environment, can be inactivated at room temperature in 6 months. At temperature 100 in 20 minutes. Yes, just imagine this. You should boil something, boil for 20 minutes, not for a minute, not 5, not even 10, 20 minutes. Yes, rather resistant. At 160 dry fever in 1 hour. In 120 degrees in 30 minutes. In plasma in 25 years. In refrigerator in 6 months. At pH 2.4 in 2 hours. In usual concentration of disinfectant solution in 2-7 days. Really resistant, so it's have even context household method of passing one from one person to another. Epidemiology. 33% of the population have hepatitis B virus. 350-400 million of them are carriers of HBS antigen. On Russia, more than 1 million of carriers. Source: human with acute and chronic hepatitis. HBS antigen carrier. Groups of high risk: medical workers contacting with blood, recipients of biological tissues, patient with often parenteral infusion, mentally retarded and looking after staff, patient with chronic disease of the liver, children birthed from the mother's carrier of HBS antigen, drug addicted and commercial sex workers, homosexual and persons with HIV infection, if they're not use contraceptions barrier, inhabitants of hyperendemic by hepatitis B regions. By the way, in Russia, as we have such a big problems with hepatitis, now what maybe last maybe 10 or 15 years, but not more than 10 years, I guess. But now we have total immunization of people from hepatitis B since birth, even without risk. So the new generation of Russian people, our teenagers and kids, already will be vaccinated. And this is how it works. Here we have vaccination in hepatitis B, and it's rather effective. In Russia, 188,000 patients with chronic hepatitis and cirrhosis and annually registered, and 6,000 of them died. Frequency of revealing of markers of hepatitis B virus. Among medical workers, 33%, among the patients with venereal disease, 49%, among the donors of blood, 14%, among the population, 3 and 8%. Mode of transmission, parenteral. So it's maybe sexual nowadays, mostly horizontal, more than half of all cases, almost 52%. Intranatal and postnatal, vertical, 10 to 50%, it's depend. Transplantal, 6 to 10%. Hemipercutaneous, home contact, yes, it's almost contact household, 6 to 10%. Artificial modes of transmission, all medical manipulation with damage of skin and mucus. Intravenous drug addicted, tattoo, cosmetic procedures. Infecting dose of blood in volume of, I won't even read this number, like really small amount of blood may be infected. Frequency of newborn infection, 0.2 to 40%, depending on activity in mother and actions that are made after the birth of the kid. The risk of chronic HBS carriage. Now, think of this and remember this fact because it's often when you confuse this. At newborn, risk of colonization is really high, 90%. So if a newborn infected, probably go to chronic form. The first year of life, 50%. More than first year, 20%. And in adults, percent of colonization, it's only 5 to 10%. So mostly acute hepatitis B in adults and with recovery. And only 5 to 10% have chronic form and eventually cirrhosis and liver cancer and so on. One injection of blood with HBs antigen causes a disease in 90% of cases. Hazard after one prick of infection needle, 34%. In 50% of cases, the source of infection is not revealed. Again, person jaunted and he has some tattoo, maybe it was without proper hygiene measures and maybe it was a source of his infection. Again, piercing, blood transfusion, injection, tattoo, that may be a source of infection. Pathogenesis. Fixation of the virus on surface of hepatocytes through protein pre-S2 via endocytosis. Undressing of the virus and beginning of replication. Nucleocapsid is invaded in core of hepatocyte, where due to viral DNA polymerase, the viral chain is completed. Synthesis of viral proteins, formation of the external envelope with viral antigens, replication of virus is possible in cells or bone marrow, spleen, monocytes, and lymphatic tissue. Immune response with severity is depressed completely. The disease does not develop. Again, in hepatitis B, your immunity may be your enemy. Hyperimmune reaction, causes of a fulminant form, but when immunity is depressed, the disease is not developed. Yes. Infection, then incubation. It may be subclinical infection asymptomatic, then usually recover immunity. Clinical infection, bacterial or anecteric, maybe going to fulminant hepatitis, which more often live, not often live to death, or maybe recovery with immunity. Chronic carrier, maybe chronic persistent replication or chronic active hepatitis, which is chronic active hepatitis usually leads to cirrhosis, while chronic persistent hepatitis more often cause to hepatocellular carcinoma. And again, death in both cases. or cirrhosis linked to hepatocellular carcinoma 2. And of course, thanks. Clinical characteristic. Cyclical disease with expressed jaundice, incubation asymptomatical, duration 40-180 days, but average 2-3 months, but up to half a year, up to. Can be revealed increased ALT, even incubation period. Initial period, duration till 2-3 weeks, starts gradually, intoxication, hyperthermia, headache, weakness, dyspepsia, meteorism, changing in color of urine, hepatomegaly, painful palpation, cutted tongue with white or gray fur. In initial period of HBV may be again dyspeptic astenovegetative, but here it may be also with rashes and it may be arthralgic, which is not typical for hepatitis A. Arthralgic initial period, which is 25-30%, pain in joints without external changes, sometimes redness, edema. Frequency of signs initial period, lowering of appetite 95%, weakness 94%, nausea 2/3 of the patient, heaviness and hypochondrium 57%, joint pain, muscle pain 66%, headache 34%, meteorism 32%, vomiting 1/3 of the patient, abdominal pain approximately 1/3 of the patient, fever 22% only, dermal itching 21%, diarrhea up to 10%, giddiness 8%, and dermal eruption up to 8%. Climax, icteric period, jaundice with which is appears patient state is worsened. Additional diagnostic criteria, remember hepatitis A better and hepatitis B worsen after jaundice appears. Again, the same scene. First painted the mucosa of peripheries and sclera, later skin of the trunk and then extremities. Continuous 4 weeks, is much longer than hepatitis A. Again, progression, peak, and attenuation. Discolored stool, dark urine, and so on, enlarged liver and spleen. The same as hepatitis A. Cardiovascular syndrome may be. Altralgia disappears, but intoxication, dyspepsia, and asthenia is increased. Hemorrhagic changes here, it may be, mostly of course in severe form, petechial exanthema and anthema, nasal bleeding, microhematuria, or profuse bleeding in severe form. Again, in moderate to mild form, hemorrhagic changes are absent. Cardiovascular too, by the way. Reconvalescent, recovery of liver function and regeneration of tissue. Long term, from 1 to 3 months to 1 to 2 years. Jaundice disappear gradually, astenovegetative syndrome. Again, this is some maybe rash appear. This person with cirrhosis, again, it's chronic hepatitis, yes, which he was living for 20 years probably. It's not something that happened in a month. Again, cirrhosis. Laboratory characteristics, specific method. Again, virological method, detection of virus in the liver tissue biopsy, not recommended really. But PCR is a good idea. Within the first week of the disease, it's already positive. Serological confirmation, ELISA, revealing HBs antigen already in incubation period. HBe antigen is marker of active replication. Anti-HB core antigen immunoglobulin M in acute period, acute virals, hepatitis B, and anti-HB core immunoglobulin G in chronic viral hepatitis B. The maximum titer in 2-4 weeks persists for 2-6 months. Circulation of HBs antigen within 7-8 weeks, or HBe antigen within 3-4 weeks from the onset of hepatitis B virus indicates chronization. Again, HBE within month, yes, more than a month, and HBS more than 2 months. Already we think of colonization. Again, now be attentive in this part. Diagnostic markers of viral hepatitis of various etiologies. HBS for hepatitis B virus, indicator of contact with hepatitis B virus or its presence in the blood, acute infection, chronic infection, or healthy carrier. HBE antigen, indicator of active replication of virus, high infectivity of blood, high risk of vertical transmission of hepatitis B virus. HB core antigen, indication of presence of virus in the blood, in the body. DNA hepatitis B, presence of virus and its active replication, maybe both in acute and chronic form. Anti-HBs antigen indicate past infection or presence of post-vaccinated immunity. Anti-HB core immunoglobulin M, index of active virus replication. So it may be an acute period or recurrence of chronic infection, yes, reactivation. Anti-HB core immunoglobulin G indicates exposure to the virus in the past. Anti-HBE immunoglobulin indicates a possible completion of the replication. DNA polymerase indicates of the presence of virus and its active replication. Non-specific methods. CBC, leukopenia, normocytosis, neutropenia, lymphocytosis, decreased platelets, increased TSR. Biochemical of blood. It increased transaminases, initial period and climax, ALT, AST, markers of cytosis above normal in 20 times at least. 20. Not even 10. 20 times at least. 20 to 100. Reduced in reconvalescence. Hyperbilirubinemia due to direct fraction in enteric period, indicator of the severity of the disease. Increase, if we talk about acute hepatitis, of course. Increase significantly alkaline phosphatase, LDG. Increase blood urea, sometimes in severe forms. Coagulogram, no change in moderate form. In severe form, maybe changes. Urobilin again in urine. Diagnosis of HBV is based on a combination of factors. Cyclic development, presence of prodromal initial period, sequences of development of severe intoxication, jaundice and hepatitis pulmonary, hemorrhagic syndrome in severe form, laboratory data, hyperbilirubinemia, mostly due to direct fraction, increased transaminases, urobilin in urine, markers HBs antigen, HBe antigen, anti-HBs antigen immunoglobulin M, HB core, I think they mean pre-core, anti-HBe antigen immunoglobulin M, anti-HB core immunoglobulin M. Diagnosis of viral hepatitis B is based on combination of factors: epidemiologic analysis, blood transfusion, surgical and dental treatment, tattooing, manicure, pedicure for the last 6-8 months. Unknown unprotected sexual contact, intravenous drug use, homosexuality, prostitution, sexual contact with a carrier of HBs antigen, the mother carrier of HBs antigen. Principles of treatment of viral hepatitis. Purpose: reducing the physical, emotionally, and dietary stress. Heterotropic antiviral therapy is not assigned, only a tendency to colonization. So usually it will be not at least first 3 months. It will be at least 4 months of treatment, or maybe in half of the year after start of disease, when it's tendency to colonization, then you may prescribe antiviral therapy. Because again, remember, in 90% of the cases, or even 95%, person will recover without antiviral drugs. So only if we see tendency to colonization, then we prescribe antiviral drugs. And in other case, it will end by recovery even without your therapy. Obligatory hospitalization and isolation of the patient. Basic therapy, again, it's treatment, basic therapy, it's treatment of hepatitis A, by the way. It's bed rest, diet number 5, plentiful drink. Or desintoxication, which is plentiful drink, antiresorbents, maybe lactulose, intravenous solution of 5% glucose, antioxidant, tocopherolus, corbic acid metabolites, hepatoprotectors. Again, in cytolytic form, you can use any hepatoprotector. You could talk about static forms, ursodeoxycholic acid. Symptomatic treatment: antipyretics, antiemetics, antispasmodics, purgative drugs. Dispensary observation within 6-12 months is hepatitis A, 1 to years hepatitis B. Hepatic coma. It's what may happen during acute hepatitis. Plus, it's what fulminant hepatitis result in rather often. Complication of severe and fulminant form of hepatitis B or hepatitis B plus D. Reason: pathogenesis. Liver destruction leads to redistribution of ions in the hepatocytes, disturbance of inactivation of metabolites, accumulation of ammonium in the blood with tropicity to CNS, edema, swelling of the brain. Clinical sign of a developing coma: increase of jaundice with a rapid increasing of the level of bilirubin, appearance of nausea and vomiting, developments of anorexia, inversion of sleep, insomnia, appearance of hemorrhage, decreasing of ALT/AST, decreasing of size of the liver. It's things that should make you worry. But again, start with analysis. Usually first page sign analysis, then in clinics. And you should prescribe treatment. Treatment you may read yourself or you will discuss with your teacher. Oh my god, it will be new probably. But again, treatment of hepatic coma is one of your topics when we talk about viral hepatitis. And it's usually about active desintoxication, glucose, and of course, in the first place, corticosteroids. Just know the dosage. Corticosteroids, here it's life-saving therapy. Now, a few words about hepatitis E. Morphology and characteristics. Hepatitis E virus. Classification: unclassified, stegovirus, and alpha virus-like. Non-enveloped, acid stable. Well, in several words about hepatitis E, it's clinically and epidemiologically it's similar to hepatitis A, but hepatitis A is spread almost worldwide, while hepatitis E mostly in tropical countries. Endemic mainly in Asia, Middle East, North Africa. Fecal oral transmission human to human. Contaminated water supplies in tropical and subtropical developing countries, mainly young adults. Mature infant transmission occurs and often fatal, whereas its clinical characteristic, again, similar to hepatitis A, but it has high mortality rate in pregnancy. And so pregnant women especially should be hospitalized and intensively treated because, which is untypical for hepatitis A, but typical for hepatitis E, high level of mortality in pregnant women. Again, clinical characteristics similar to hepatitis A can cause several severe acute hepatitis. Subclinical infection is more common. Attenuated virus from animal reservoirs may be. Low dosage affected, often asymptomatic, no chronic infection, but up to 20% mortality among pregnant women, especially in third trimester. It's really high. Well, and a few words about hepatitis C. Hepatitis C, mostly modes of transmission the same as for hepatitis B. But usually it's in 80–85%. Different textbooks give different data. Goes to chronic form. Only 15–20% have spontaneous recovery. Mostly starts with asymptomatic clinics, and only some people have acute form with jaundice that will be clinically similar to hepatitis B, but mostly after infestation there will be no symptoms and will have latent course. This infection, again, chronic latent course, and only in 20 years or something it will result in cirrhosis or hepatocellular carcinoma, or cirrhosis and then hepatocellular carcinoma. And of course, it's something that's hard to treat in this late stage. So again, usually we don't give antiviral drugs in acute period with high ALT/AST. There in hepatitis C, you have only two markers. Oh, two main markers. Yes, PCR of the blood and ELISA immunoglobulin M for acute or exacerbation of infection, and immunoglobulin G for chronic infection or infection in the past. So if you have only immunoglobulin G and you don't know if it's acute infection, if it's chronic infection, person, one of these lucky ones that recover spontaneously, again, immunoglobulin M may be negative if it's non-active for the moment. Biochemical test may be normal if it's not active for the moment, so you check PCR for the virus. And the next thing, again, acute form treated the same in the same way as hepatitis B, basic therapy. But if we talk about chronic form, at least know what the medication is, because in most textbook, like especially that's up to 2012, it's written some old treatment with ribavirin and interferons. It's still sometimes used, but rather seldom and to comorbid patients. Nowadays, from 2012, we have new golden standard of antiviral therapy of direct action, which is cheaper and more effective and have less side effects. And this is this on the slide. In usual form, dalactosivir and sofosbuvir used for 12 weeks and its result almost in 100% recovery. In people with liver cirrhosis, dalactosivir used but plus interferon and ribavirin for 24 weeks, and treatment may be positive in 64%. It seems to be not that high, but you haven't seen the old treatment. It's still better than it was. If it's together with HIV, dalactosivir and sofosbuvir, 12 weeks, again, a bit lower results, about 97%. With negative reaction to medication, dalactosivir and sofosbuvir, or dalactosivir, sofosbuvir and ribavirin on 24 weeks. It's for first genotype. For second genotype, usual form, dalactosivir and sofosbuvir, 24 weeks, yes, from the start. So genotype is important. With liver cirrhosis, we don't treat it. Against HIV, dalactosivir and sofosbuvir for 12 weeks. With a negative reaction to medication, we don't treat it. For the third genotype, usual form, 12 weeks. Liver cirrhosis, dalactosivir, interferon, and ribavirin, 16 weeks. 50% chance of recovery. Against HIV, dalactosivir and sofosbuvir, 12 weeks. 57% of recovery. With a negative reaction to medication, again, dalactosivir and sofosbuvir, or dalactosivir, sofosbuvir, and ribavirin, 12 weeks. You don't need to know all of this. Just you need to know that different henotypes treated from 12 to 24 weeks, and usually is dalactosivir and sofosbuvir. Interferon and ribavirin is still sometimes used, but usually in comorbid pathology or with negative reaction to medication. That's what you need to know. And treatment of fourth genotype, the features of pathology is in usual form dalactosivir, interferon, and ribavirin, 24 weeks. But again, not that high result, 84% only comparing to 100. And with liver cirrhosis, lactoferrin, interferon, and ribavirin, again 24 weeks, but here it's not that bad, 78%. And now this is considered gold standard, and it's much better than previous treatment. Again, we treat chronic hepatitis C in remission. Yes, when LT-AST is normalized and so on, then we prescribe these antiviral drugs. Other details and other, you will discuss on your classes. Thank you for attention and goodbye. Stay healthy.